Hi, everyone, and welcome to tonight's webinar, Genomics in Cancer Care. Um, my name is Emily Kelly, and I'm one of the peer support pharmacists, and delighted to welcome you here tonight for a really interesting evening. Before we get started, just a reminder, the webinar will be recorded, so we ask everyone to have their microphones muted. You can have your videos on and off as you wish. If you experience problems with connectivity, it's probably best just to turn off your video. If you've difficulties with sound, just make sure your speaker is turned up on the actual keyboard. And if it's still having a problem, you try logging in or out again and see does that work. You can use the chat function for questions or comments throughout the presentation. And we have about 45, 50 minutes of presentations and then time for questions at the end. And we may use anonymized information from the webinar after this. And Grace is going to pop a post-webinar survey into the chat box as well. And we'd really appreciate if you'd fill that out because it helps us to know what you'd like to hear and see in the future. So without further ado, I'm going to introduce Dr. Clare Meaney, Chief 2 Pharmacist at the National Cancer Control Programme, and Dr. Caitriona McCarthy, Consultant in Public Health Medicine at the National Cancer Control Programme too. So I'll hand you over to Clare now, which I'm sure is going to be a really, really interesting evening. Thanks, Clare.
Thank you, Emily, and thank you all for logging in to this presentation this evening and for taking time out. So I'm just going to try and share my slides there. Is that okay? Can you all see
Yeah,
them? Yeah,
that's perfect. Yeah,
that's
all good.
great. So tonight, myself and my colleague Caitríona, we're going to talk about genomics in cancer care. So my name is Clare. I'm a pharmacist in the systemic therapy program in the National Cancer Control Program. And so my talk is going to focus mainly on genomic testing, predictive for drug use. So just move along. Right. And so first of all, I just wanted to go through some basic terms. So what is genomics? It's basically the study of an organism's genetic material. And for us as humans, that's DNA, and we all know what DNA is, deoxyribonucleic acid, and that carries our genetic information, and it's like an instruction book that contains the instructions for how our body grows, functions, develops. And then when we're talking about the genome, what are we talking about? We're basically talking about one whole set of your DNA, and your whole DNA consists of about 3 billion nucleotides, those adenine, guanine, thymine, cytosine that we all learnt about. And within the genome, 99.9% of that DNA is the same. So it's really only about 0.1% of it that's different. And that doesn't sound like a lot, but when you think about the number of nucleotides, 0.1% of 3 billion is a large number, so that accounts for quite a bit of variation, and it's why we're all not the same. There's quite a bit of variation among all of us. And then when we're talking about genomic medicine, really what we're talking about is utilizing genomic data to guide diagnosis, predict disease and prognosis, and help us determine therapeutic options for patients. And so then in terms of cancer, well, why is genomics important in cancer, we might ask? But cancer really is a disease of the genome. It's caused by changes in our DNA that are harmful and that disrupt our normal cell function. And changes to our DNA, these genomic changes, we call them variants or mutations. And these can be inherited or can be acquired over time. And I'll talk about those in the next few slides. But I suppose I should say that not all genomic variants are harmful. They don't all cause us any problems, but there are some genomic variants that do have implications for our health. So in terms of inherited variants, these are also referred to as germline variants or constitutional variants. And personally, I like the term inherited because these are variants that we do inherit. We are born with them. They're present in every cell of our body, and we can pass them on to future generations. So I quite like that term inherited. And relation to cancer, I suppose, in terms of inherited variants that have an effect on cancer, we're all familiar with the BRCA gene. And Trina will talk about that more in her talk. And I suppose the identification of a BRCA gene in a person, it identifies that they have an elevated risk of developing cancer. But we can also have another type of inherited variant that may affect us in terms of our drugs and treatment. We can inherit variants that affect drug metabolizing enzymes and drug transporters. And this is where the area of pharmacogenetics comes in. And really, this is broader than cancer because we can have enzymes that affect different classes of drugs affected. So, say, for example, with our statins, um, variants in the statin transporter gene may increase the risk of statin associated musculoskeletal symptoms. So, we have that type of genetic variant as well. And I'll talk about an example in the cancer space later on. But however, most of the DNA variations that cause cancer are not inherited. In fact, there are what we call like somatic or acquired variants. So these are variants that are arisen as the tumor has evolved. We acquire them over time. We're not born with them. We can't pass them on to our offspring. But what these tumor or somatic variants are important in helping us determine the prognosis for the cancer, and it informs treatment options for the cancers because these somatic variants, there's been a lot of work done on developing drugs that target these particular somatic variants in specific cancers. So this really is the basis of personalized medicine in cancer. And I suppose over the last number of years, there's been a great growth in personalized medicine and cancer. And this has been facilitated by the identification of these somatic genomic changes in tumors. And if we look at, there was an OECD report in September of last year, and they showed that 81% of new cancer indications that were approved by the European Medicines Agency between 2020 and 2022 were all targeted therapies. They were all being directed at a specific genomic variant. And so it's really important that we look at a patient's tumor now to see what are the genomic changes in it when we're trying to identify treatment options. So for example, in colorectal cancer, people who've metastatic colorectal cancer who are being considered for treatment, we take their tumor and we extract the DNA from it, and we look to see what biomarkers and what genomic variants are present in that tumor, and then that helps us to identify what is the most suitable drug for treatment. Because say, for example, we do know that in colorectal cancer, if we identify that this tumor has a KRAS variant, well, then we know that that patient will not benefit for treatment with cetuximab and panitumumab. So just knowing what's in the tumor, what variants are present, it helps us to personalize the treatment. We'll choose the treatment that's going to give the best potential for response and avoid harmful side effects for the patient. And I suppose people think of personalized medicine in cancer as something new, but it's not new. It has been developing over the years, and in the next couple of slides, I'm just going to talk about some examples that have been in place for the last 20 years or so. Because back in the early 80s, there was kind of a one-size-fits-all approach to treatment in cancer. You had breast cancer, you get this treatment. Colorectal cancer, you get that treatment. And it was basically like in breast cancer, patients got chemotherapy. It was cytotoxic. It was a bit like a bomb. It killed the cancer cells, but it also killed healthy cells, which caused a lot of toxicity and side effects for patients because we didn't understand some of the molecular characteristics and the different types of breast cancer. But then in 1986, the HER2 protein was identified that this protein was overexpressed on a certain proportion of breast cancers. About 1 in 5 breast cancers overexpress this protein. And basically, they worked out that the overexpression of this protein was linked to outcomes, that these patients who had overexpression of the HER2 protein, they didn't do so well. They had an increased risk of occurrence and an elevated risk of mortality. So now they had identified this protein on the cells. They looked at the thing, what could they do about it, and it provided the basis for developing the monoclonal antibody trastuzumab Herceptin, which was developed to bind to this receptor and block the signaling which was causing the increased growth. And that drug was approved by the FDA in 1998, and it really had led to significant improvement in clinical outcomes for patients with HER2 positive cancer. And that ad there is for a film which kind of tells the story of the life of the clinician who was instrumental in developing trastuzumab and the role of and the impact that Herceptin had on women's lives. So, and Herceptin has moved, it was approved originally in metastatic cancer, but it's used now much earlier. And we have a number of other HER2 targeted treatments, which are all listed there, which have been developed. And these are all treatments that are well established and are administered in the hospital setting. And I suppose this is what I think that many of you will be familiar with and will have dispensed imatinib or Glyvec in community pharmacy for treatment of chronic myeloid leukemia. And when this drug was approved in 2001, it was really seen as the magic bullet. Basically, chronic myeloid leukemia is characterized by the formation of this abnormal fusion gene, the BCR-ABL fusion gene. And this creates the BCR-ABL protein. And imatinib was designed to specifically bind to the ATP binding site on that protein. And it basically delayed the progression of the disease from the chronic phase into the acute phase. And basically, when it was approved in 2001, the clinical data was so good, it was the fastest approved drug ever approved by the FDA at the time of its approval. And it really has transformed this disease from being a fatal disease into a much more manageable chronic disease. And now, as I said, that was approved in 2001. We have the newer TKIs, nilotinib and bosutinib, which would also be dispensed in the community setting. And we now have 20-year overall survival data for imatinib, which was published there in 2019. And if we look at this graph here, this black line really is what we're looking at, its overall survival. And basically at 5 years, you had a nearly 90% overall survival. And now we're out here at 19 years and we have a 50% survival. So really, it was dramatic clinical benefit for these patients, and we really see the benefit of targeted therapy. And I suppose when we talk about advances in personalized medicine, I think non-small cell lung cancer is the tumor type that comes to mind the most in people. Because this timeline here shows your EMA approvals between 2005 and 2023 for targeted therapies for patients with advanced stage non-small cell lung cancer. So on the y-axis here, we have the different variants that have been identified in non-small cell lung cancer. And then we can see the drugs that have been developed that target these different variants. For example, crizotinib in ALK non-small cell lung cancer. And basically, I suppose looking at this graph, what we can see is really in the last 10 years, we've had a huge number of drugs approved by the European Medicines Agency for the treatment of non-small cell lung cancer. They're all targeted treatments. They're all oral treatments. So they're all dispensed in the community setting. They allow patients to have their personalized treatment at home. They can avoid going to hospital to the day ward for parental chemotherapy. And this targeted treatment offers, increased overall survival and improved quality of life for these patients. So there really has been a lot of development in this area. And I suppose what you can see is back here, we were just looking at one marker, EGFR, and now up here we have a lot of different markers that we're looking at in the genome of the tumor. And I suppose back there we would just look at one gene at a time and it was a single test. But now that we have a lot of genes, it's important that we can test them in a timely manner. And especially in lung cancer, because we often only have a small amount of tissue and it isn't always practical to go rebiopsying the patient. That isn't feasible always. So it's important to be mindful of the tissue, and next generation sequencing really has made it possible for us to what next generation sequencing does is it allows you to analyze multiple genes in parallel. And now you might just do five, you might do 50, and even now in some of the hospitals, they're looking at developing capacity to do 500 genes at the same time. So it takes a bit of time, but it's much more efficient than doing one gene at a time. Obviously, it's much more cost effective, and it's better in terms of managing your tissue. So the next generation sequencing now is standard of care for patients with advanced non-small cell lung cancer. They would routinely have a gene panel where a number of genes would be analyzed by next generation sequencing. And in terms of, I suppose, what I'm involved with in the NCCP, here we look at this timeline here shows the progress in somatic genomic testing over the last number of years. And I suppose all this testing here on this slide is focused on testing predictive for drug use. And we started off in 2012 with a simple KRAS testing in metastatic colorectal cancer. And as the number of gene markers increased as treatments become available, we've added on the different testing pathways as needed. And now we have routinely for patients a standard of care in advanced colorectal, melanoma, and non-small cell lung cancer. They would have genomic testing done for a number of variants because we have a number of targeted treatments available in those cancers. And I suppose what we do is we work with pathologists and medical oncologists to make sure we have a plan in place for testing for new variants as they're required. So when a new drug is approved for reimbursement, we basically want to have a plan in place that has the testing for the testing. So to ensure the patients have access. So any new testing that's coming down the line, we just work with the clinicians to make sure there is a plan in place for that testing so patients can access the new treatments coming online. And all that testing, as I said, is focused on predictive for drug use. We are kind of branching out, and at the moment we're developing a genomic test directory for cancer, and this is focused on the standard of care somatic genomic tests that are diagnostic, prognostic, and predictive for drug use for the different solid tumors and hematological malignancies. So what we're trying to do is establish a set of standardized criteria for genomic testing in the different tumor types. And so far, we have developed a genomic test directory for colorectal, breast, ovarian, and urothelial cancer. And these are all published on the NCCP website and at the link there. But all these links are provided in the resources that will be made available with the webinar later on the IOP website. And I just want to flag the National Genetics and Genomics Office within the HSC because our work on the genomic test directory cancer kind of aligns with their work. Their role is to implement the national strategy, which is pictured there for genetic and genomic medicine. And as part of that, they are developing a genomic test directory for rare and inherited diseases, and that's available on their website. And as I said, the links have been provided in the resource document. So now I just wanted to talk about, in these next few slides, just to highlight some examples of cancer genomic testing in practice. So the first one, if you remember, we were just talking earlier about inherited variants. I remember I mentioned pharmacogenetics. So this really is an example here of pharmacogenetic testing. So and this is for DPD testing prior to your first treatment with capecitabine, which is an oral drug dispensed as Xeloda, dispensed in the community setting. And it also applies to some parenteral drugs. Because basically in 2020, the European Medicines Agency recommended that patients undergo testing for DPD prior to treatment with fluorouracil, capecitabine, and tegafor. And really, this was all about trying to identify patients who were at increased risk of severe toxicity due to DPD deficiency, because the DPD enzyme is responsible for the breakdown of these drugs. And one way they identified for looking at DPD deficiency was by looking at the DPYD gene, because there are some variants in this gene that are associated with DPD deficiency. So, as I said, this is an example of a pharmacogenetic test in practice for a cancer drug. And basically, if a patient is identified as having complete deficiency of DPD, well, they're not suitable for treatment with these drugs. It's a contraindication. They're excluded from treatment with these drugs. If you have a partial DPD deficiency, you a clinician can consider starting you at a reduced dose, and you'll just be monitored, and it may be increased, and they'll just monitor depending on the individual person to see how it see how it what's most suitable for them. So I suppose there was a big piece of work, and we made all our NCCP SACT regimens, which contain these drugs, have incorporated all these recommendations made by the EMA. So you can see it's excluded if you have deficiency, and down here we have the recommendations in relation to modifying dose in patients who are identified with to have a partial DPD deficiency. The next example I wanted to talk about were the PARP inhibitors. And these are targeted therapies used in the treatment of breast cancer, prostate cancer, ovarian cancer. And again, they're all oral agents, so you may come across them in your practice. And the reason I want to highlight these is because here we have a bit of overlap between inherited and somatic variants in determining eligibility for drug treatment. For example, if you look at this drug here, talazoparib, which is used in the treatment of a specific cohort of breast cancer patients, in order to be eligible for this treatment, you have to be identified as having a germline BRCA variant. And as you can remember, that's the inherited variant. So that having an inherited variant does have implications for that patient beyond just the treatment for this current cancer. There's other considerations to be taken into account for their management, and also it has implications for their biological relatives. So any patient who is on the talazoparib has this variant, just so you're aware, and these patients will have been referred to the cancer genetic services and offered the special genetic support in relation to this. When we're talking about the indications in prostate cancer, we have olaparib and then the combination product Akega. It's not quite as clear cut because the indication there allows for the presence of a germline and or somatic BRCA mutation. So it won't be obvious to you dispensing the prescription as to whether this patient has a germline or a somatic variant, and they may not be quite sure themselves. But basically, if you're identified as having your tumor has a BRCA variant, well, then you will be offered germline testing to determine whether that variant is inherited or not. Because obviously, if you have a germline variant, it's going to be in your tumor. Because if you have a germline variant, it's in every cell of your body. But if you have a tumor variant, you have to test. If you're identified, first of all, with a tumor variant, you have to go and test the germline to see if there is an inherited component with it. And I suppose we've developed, it's just up there on the slide, a patient information leaflet for patients to to talk them through testing to inform PARP inhibitor treatment. And it basically calls out what a germline bracket test is, what a somatic or tumour bracket test is, what type of test you might need depending on the cancer that's being treated, and what the results might mean for you. And that's available on the website. And again, in the ovarian setting, there are a number of indications in the ovarian setting, and depending on the indication, you may have a germline or a BRCA or a somatic BRCA variant if you're being treated with these drugs. And so then moving on from the PARPs, I guess we're back to lung cancer, which is really the one where we have a lot of targeted treatments. So here, and lung cancer is the most common cause of cancer death worldwide, just still. So here, in this example, we have a man with advanced non-small cell lung cancer. He's been considered for treatment. So what do we do? Here, we send his tumor to be analyzed. We look at the DNA to see what variants are present, or if there are any variants present. We look for all these different biomarkers here. And in parallel, we also send a sample of their tumor for immunohistochemistry testing, which is basically they stain the tissue and look at it under the microscope. And what they're looking for is PD-L1 protein expression. And this is linked to the use of immunotherapy. The patient may be eligible for certain immunotherapies depending on that test result. So when the tests come back, really what you're looking at to see is if there's a targeted genomic variant identified, then the person will be matched that treatment, the treatment that's targeting that genomic variant. If we don't identify any genomic variant and their PD-L1 expression is high, greater than or equal to 50%, then they may be suitable and be considered for immunotherapy treatment on its own. If the PD-L1 expression is less than 50%, then they may be considered for chemotherapy or chemotherapy in combination with certain immunotherapies. So really, we can see here the genomic makeup of the tumor is really informing what the patient is going to be treated with. And just this slide here just shows the different biomarkers and the drugs that are available in Ireland to target these different biomarkers. And I suppose I just want to highlight this last one here, the NTRK inhibitors, entrectinib and larotrectinib, because these are last line treatment options. These are approved for use only when you've exhausted all other treatment options, and they're not just used in lung cancer. They're available for all solid tumors that express the NTRK fusion as a last line of treatment. But it's a very rare mutation, and it's not found that often in lung cancer. And there's a managed access protocol in place for these drugs through the Medicines Management Program. The next example then, I suppose, is one you may all have heard of in the media over the years, Oncotype DX testing in breast cancer. And this basically, it's a gene expression profiling test, and they look at, it's a proprietary test owned by one company, and they look at the expression of 21 different genes, and it's for specific, it's not for every type of breast cancer, it's for a specific cohort of breast cancer patients. And basically, they look at the breast and look at, you have this test done and you're given a recurrence score between 1 and 100. And if you have a low score and it's in the low risk zone, what it basically means is that the risk of your cancer reoccurring is very low, and that you may not benefit from chemotherapy after your surgery. So really, this was a huge thing because it identified patients who could safely avoid chemotherapy and avoid all that, what that meant for them and their families. And Ireland when this was approved for use in 2011, Ireland was the first country in the EU to approve this in the public setting. And Irish women were heavily involved in the trials that led to the licensing of this product. There was about 1,000 Irish women who took part in the clinical trials that led to the approval of this test, and a number of Irish clinicians are still doing a lot of research and have published a lot of work on the real world evidence on the benefit of this test and what it means to women. So I suppose I've talked a lot now about somatic genomic testing, and when I've been talking about that, what we've been doing all the time is testing the tissue. And that, and but sometimes we don't have a lot of tissue, and sometimes it's, as I said, with particularly lung cancer, it's difficult to go back and get more. So there's been a lot of work going on, looking at the development of liquid biopsy. And so this is a less invasive way of examining a patient's cancer. You can basically take a blood sample, and how does it work? Well, your cancer cells, they release small amounts of their DNA into the bloodstream, and that's known as circulating tumor DNA. And then the liquid biopsy can detect these pieces, and it can be used to track your cancer and identify and see what's going on. So there's a lot of research going on into this, and has lots of different applications. For example, in the UK, you have the NHS Galleria trial, which is looking at trying to detect cancer at an earlier time point. We can also potentially use the liquid biopsy in the future to monitor treatment to see how is the cancer doing. After your treatment is finished, you can use it to check for reoccurrence and see how is it still working, or is the cancer still in remission. And we can use it like we do the tissue testing to identify the somatic variants that would inform treatment options. So I suppose that's all very exciting. We're waiting to see that develop and be validated for clinical practice. And then with all this genetic information and genomic information we are collecting and doing more and more analysis, we see that molecular tumor boards are going to become important. And these really is because the more genes we're analyzing, we're creating a lot of data. And what does that data mean? It requires, us bringing together experts to discuss the data and identify what's the best treatment for patients. And I suppose we would see this really happening for patients with rare cancers, or patients where we're getting unusual results, and we need to try and work together to identify the best treatment for them. And sometimes there may be no treatment. That may be the result, but at least they would have been discussed and worked out. And so just to finish my last slide, I tend to use this slide when I talk about genomic testing. We've achieved quite a lot, and we've come a long way. There's a lot of testing going on, but there's a lot more that's coming down the line, and it's going as it expands out. So thank you very much, and I'll pass over to my colleague Caitríona.
Thanks, Claire. And sorry, I'll just share my slides here. It's coming up okay, yeah?
Yeah.
So thanks everyone for the invitation to speak to you today along with Claire. So my name is Caitríona McCarthy. I'm a public health consultant working in the National Cancer Control Programme. So my first disclaimer is I'm not a clinical geneticist. I'm a public health trained doctor who's involved in the planning and development of services kind of right across the inherited cancer predisposition space, but not an expert in any one of the many areas I'll be touching on here, but hopefully it'll be of interest to you anyway. So I'm going to start just with what Claire had mentioned around the difference between the germline and the somatic variants. And I suppose just obviously I'm talking about the inherited side of things. And just to remind you again that these are variants that are present from birth, so they're in your in the egg and sperm, so pretty much almost exclusively inherited or de novo mutations at that stage. present in every cell in the body. So unlike your somatic variants that are only in your tumour, they'll be everywhere. But as Claire mentioned again, everywhere, including in the tumour. So that's quite relevant to the sort of overlap areas. And again, the fact that they can be passed on to the offspring, so very relevant for your own family then. So that's something which I'll come back to again. In terms of actually what sample you're taking to find a germline variant, the most common would be doing a blood sample, but saliva testing, you can extract DNA from that. I think it's just a little maybe harder to extract the DNA from saliva, but it can be very good quality DNA. So there can be good testing done in either of those. But again, any other, often there can be skin biopsies used for whatever reason. So there are other options that you can use to actually carry out the testing for a germline variant. And the other piece of terminology I wanted to mention would be, first of all, inherited, germline, constitutional. Again, you know, they're all kind of used interchangeably. So it doesn't really matter which, but, you know, just depending what talk you're at or what paper you're reading, you know, they all pretty much mean the same thing. The other one would be the use of the term mutation or a gene variant or a gene alteration. Again, just different ways of saying the same thing. The one thing I would mention is that we had done a piece of work with people with a BRCA gene variant, and they were a needs assessment that we carried out. And they did feel quite strongly that the word mutation isn't a very pleasant one, and that talking about a gene variant or alteration is just a nicer word to use, and you can understand that. And then when the results are being described, people talk about a pathogenic variant. So, you know, that obviously DNA, there can be changes in our DNA that don't cause any disease. So really what you're talking about in a result is this something that's either known to cause a disease or is quite likely to be one which causes disease. What goes along with that is the fact that sometimes you'll get a result where there is a change in the spelling, we'll say, of the gene, but it's a variant of uncertain significance. In other words, you know, there's often quite a lot of work goes on around trying to understand those, but looking at, you know, has that particular variant been found in other countries, and you know, what evidence is there out there as to whether it causes disease. But sometimes the answer just at the end is we don't know at this point in time, and that's just an important outcome, I suppose, to be conscious of when doing germline genetic testing with people, that, you know, you might actually not get a certain answer at the end, and it's something that often when people talk about, oh, why can't we just screen for all of these things and everybody, the more genes you test, the more likely you're going to come up with this kind of difficult situation. So again, just one to be aware of. So, I mean, cancer, and it's unfortunately a very common condition, but what features are there that would make people think, oh, this might be, you know, inherited cancer, sort of might be a trigger to think, does this person have a cancer predisposition? So if really features like having, say, multiple primary cancers in the one person, you know, multiple cancers of the same type of cancer or related cancers from known syndromes in close family members, having cancer diagnosed at an unusually young age for that type of cancer, or someone who has bilateral or multiple rare cancers. So those who work in genetics and risk assessment will do these, you know, family trees and draw a pedigree, as they'd call it, you know, in terms of you know, what age people were affected, what type of cancer, etc. And then there are other features such as sometimes the histology of the tumor that can give a clue as to the likelihood of a cancer predisposition underlying. So that can be something like a high-grade serous ovarian cancer. That type of histology will be more linked with a BRCA predisposition, whereas endometrioid or clear cell ovarian could be more linked with Lynch syndrome. So those things are useful in, I suppose, the risk assessment of somebody as well. So I'm going to focus on, in terms of going into some detail on the two more common cancer predisposition syndromes you're likely to come across. So Claire has already mentioned BRCA and also shared this image as well, if you notice this. So BRCA would be both the BRCA1 and the BRCA2 tumor suppressor genes. So if there's an alteration of those, guess what was previously probably described more as hereditary breast and ovarian cancer syndrome, but we know that there are other cancers involved as well. The reason for sharing this image, of course, is that the BRCA2 gene was described in a Dublin family, and it was Peter Daly in James's Hospital, was responsible for that, and that piece of art in James's commemorates that, and the family themselves were involved in the design of that, which is, I think, a nice piece of history for us. In terms of the level of risk, it varies depending which of those genes has been altered. The breast cancer risk, as you see there, is about 60 to 80%, and ovarian 10 to 50%. The BRCA1 risk probably be at the higher end for BRCA1 in breast and ovarian. Whereas if you have BRCA2, then you have additional cancer risks are more likely, such as prostate cancer and pancreatic cancer risk. And in terms of, I suppose, managing that risk, what can be done for people where that has been discovered. These are the three strands, I think, for most of the cancer predisposition management in terms of the core clinical pieces. Surveillance, first of all, in terms of, are there ways in which you can diagnose the cancers earlier to give people a better chance of a good outcome? And for BRCA, there's good evidence around breast imaging. It means adding an MRI, not just mammography, starting at a much earlier age and at a higher frequency than you'd have in a population screening program. Unfortunately, for ovarian and the other cancers, there isn't a strong enough evidence for surveillance around that, and that should really only be done in research settings. In terms of surgery, while there isn't good evidence around surveillance for ovarian cancer, there's very, very strong evidence around doing prophylactic surgery. So doing your bilateral salpingo-phorectomy, so the salpingo bit being taken out the fallopian tubes as well as the ovaries themselves. And that has very strong evidence in terms of improving morbidity and mortality. So really that should be done by age 40, 45, depending on the gene affected. Prophylactic surgery, of course, can be done for breast cancer as well. And your bilateral mastectomy would be the procedure. And then I suppose a lot has developed in terms of the reconstruction options. There are some very much more sort of high-tech, like complicated surgeries, but the outcomes, I suppose, in terms of those reconstructive surgeries are very good, but just long procedures, and but they avoid, say, if you didn't want to use implants, that you could actually use your own tissues there as well. Chemo prevention is an interesting one, actually, with people with cancer predisposition. The most papers report that it's probably underutilized chemo prevention. Part of that could be, sort of a reticence around increasing your uterine cancer risk through using tamoxifen if you already have an increased cancer risk for other tumor types, and other things, obviously risk of blood clots or risk of osteoporosis. So there's a balance, to be struck between using these agents and some of the other methods of reducing your risk. And the very personal decision, I think, is probably the main thing. And the link at the bottom there is to a lovely piece of work that was done with the BRCA team, the BRCA nurses team in James's, in terms of supporting people to, look at what would work for them in terms of managing their risk. So I've shared that link there, but let's just give you the little look at the webpage there as well. But, it allows people to actually put in what's important to them, and what types. It helps them just, I suppose, build up what would suit them at that point in time. So I'll just move on to Lynch syndrome there. And there's Henry Lynch in terms of who it's named after. So again, this would have been also called sometimes hereditary non-polyposis colorectal cancer. Though you can get polyps, but just not hundreds of polyps as you would in some other syndromes. So you could still get 10, 20 polyps in Lynch syndrome. The four main mismatch repair genes. So again, they're genes that are involved in DNA repair and preventing tumour occurrence. So if they are, one of those is affected, or EpCAM is a gene that's just kind of beside MSH2, as I understand it, and if that's affected, again, it can just change the expression of MSH2. So again, it's a syndrome, but depending on what the underlying gene affected is, there can be a different sort of blend of cancer predisposition that results. The three kind of common ones tend to be bowel cancer, endometrial cancer, and ovarian cancer. So overall, it's that probably about 3% of bowel cancers are Lynch-related, but that people would have sort of a 40 to 80% risk of those cancers. Plus also then, depending on which of the mismatch repair genes, you could have an increased risk of upper GI, pancreatic, urinary tract, some skin cancers. So it's quite specific to which of the mismatch repair genes. And there's actually quite a nice database where people can actually, if you know what your gene variant is, and you have your age and which organ you want to look at the risk for. So this for, say, a female who's 30 with an MSH2 pathogenic variant, you can actually look at what the predictive cumulative risk. So you can see that it's climbing up to about 40% in this situation. And then if you change the organ being looked at to the ovaries, that it would hit around 10 to 12. So it's useful for patients and their healthcare team to be able to look at sort of for their specific situation what the predicted risks are. Moving to the management of Lynch syndrome, again, just starting with surveillance. So colonoscopy would be the mainstay around the quite high colorectal cancer risk, and really would be a colonoscopy every 2 years, and the age at which that would start really would again depend on the gene variant that you're looking at. Surgery, again, gynae surgery would be recommended in almost all of those gene variants, to include the bilateral salpingo-oophorectomy that was mentioned for BRCA, but also total hysterectomy because of the uterine cancer risk. And in chemoprevention, there'd been quite a lot of research looking at aspirin, and there were the CAP2 and the CAP3 trials were the more recent one. CAP2 absolutely, showed there is a definite benefit for aspirin in terms of reducing the risk for those with Lynch syndrome. But the question that was answered then by CAP3 was, did it have to be at a quite a high dose? So like one arm was getting 600 milligrams of aspirin, which I'm sure you'd all agree is quite a hefty long-term dose to be taken. So so this was the good news, is that if you took a lower dose, about 150, but at least took it for 2 years, and that would decrease your risk. So again, still risk benefits needed to be looked at with patients with Lynch syndrome in terms of suitability for aspirin. But if they can take it for 2 years, then that definitely helps. The fact that stomach cancer is that there's an increased risk of upper GI cancers, then H. pylori testing and eradication is recommended in these patients as well. And finally, there is kind of optimism in terms of research being done to look for Lynch vaccines. So definitely there's a Cancer Research UK work been carried out in Oxford and on Lynch vax, as they describe it. So that's, I suppose, something that's very exciting for those with this particular genetic predisposition. So that's one to watch. So and this is moving away from just Lynch, I suppose, for anyone who has a known cancer predisposition, if a cancer is diagnosed, then subsequently it influences, obviously, they require surgery. Would you do the prophylactic surgery at the same time? Would they consider, if they needed to have a lumpectomy for breast, do they want to go ahead and have the bilateral mastectomy at the same time, for example? Or similarly with ovarian surgery, would they do a bilateral salpingo-oophorectomy? And I think Claire's covered quite well already, the predicted response to your systemic anti-cancer therapy knowing that you have a cancer predisposition and what that variant is can very much guide the choice of treatment that you might choose. Broader implications to mention again for any of these cancer predispositions, there are implications for the family. Cascade testing is where you broaden it out to other family members, so it's an inherited condition. So it's something which generally sits under the specialist service, and genetic counsellors would be very expert at that, but obviously it's difficult for the individual. And also planning a family, there's the psychological impact of the cancer risk, but all of those added pieces as well. And of course, the actual management to reduce your cancer risk can have adverse effects. So of the prophylactic surgery, the need to have reconstruction, the impact of early menopause, and the various side effects of chemo prevention that I mentioned earlier. So I just think it's really important to think that remember it's not just at the time of diagnosis that people need all this extra support from genetic specialists and people with an understanding of disease, but that goes on well beyond diagnosis as well. So it's good that there are quite strong support networks and patient information resources, which we'll share with the information after the webinar. But to give the example of the BRCA peer-to-peer support network in the Mary Keating Foundation is really excellent, in terms of helping people with the understanding of the condition and how to cope with it. So so just to step back again to how in general would somebody come to learn that they have a cancer predisposition gene. That cascade testing where a relative has been diagnosed with it first, that's probably the most sort of solid way of knowing what you're looking for and continuing from that. So that's a very clear path to getting a clear diagnosis. But for those with a diagnosis of cancer, it could be that their family history raises suspicion. It could be their age or features of the cancer that raise suspicion. Or there could be that somatic or germline testing being carried out for treatment purposes that Claire mentioned already. So not to go into it in detail again, but you might actually end up getting a germline genetic test to inform your choice of systemic anti-cancer treatment and end up having a pathogenic variant identified, which is something inherited. Or you could have tumor testing done, a gene variant identified in the tumor tissue, and as you mentioned earlier, you can't tell if that's something that's in your germline in every cell in your body or just in the tumor tissue. So offering germline testing is what needs to happen there, and getting into the specialist services. And just finally, I wanted to touch on mainstream testing, which is something which I suppose is coming in across not just oncology but other areas. But this is really in the oncology space. It's relevant for where a patient with a cancer diagnosis doesn't already have a cancer predisposition gene known, but that the testing for that will be offered by their own oncology team as opposed to necessarily having to go through specialist genetic services. And that's really just because of the increased demand for genetic testing, plus the increased knowledge about it more broadly, and just a real need to improve accessibility to testing. And in order to make that happen, there needs to be a team member who's trained up to provide the pre-test counselling and consent, and can explain what the test result could mean and be comfortable delivering the results to the patient. And the patient still absolutely needs to be able to see specialist services as required. So if there is a pathogenic variant found, or those unclear results that I mentioned earlier, which are quite difficult to work through. So so there's a lot of training going on, I suppose, for the broader kind of non-genetics specialists in healthcare. So we've included some of those resources in what will go out with the webinar afterwards, but also I suppose to flag that there's HSC land learning being developed specifically for mainstream testing, which people might find of interest. We hope to have that out in the next couple of months. So with that, I just want to thank you all for your attention, and I'm sharing emails there for both myself and Claire in the teams within the NCCP, and we're very happy to stay and take a couple of questions.
Thanks a million, Fiona and Claire. That was phenomenally interesting, fantastic presentation and really thought-provoking as well. There are some questions coming in. Aileen has one: is the specialist testing available to everyone in Ireland and in every hospital, and does it depend on health insurance?
No, I suppose that could mean both the germline testing. And do you want to answer from the tumour testing first of all?
Yeah, that we might take it from both angles. Yeah, exactly.
So in terms of the tumour testing, all patients with advanced non-small cell lung cancer or advanced colorectal cancer or a melanoma, it's standard of care. They do get NGS testing if they're being considered for treatment in public hospitals, and that is not, it's nothing, it's in the pub where I suppose I'm talking, and we're talking about public hospitals here. We're here representing the National Cancer Control Programme. So in public hospitals, that testing is standard of care. So patients receive it to inform their treatment choices.
Yeah, and then I suppose in terms of the germline genetic testing, I suppose currently the specialist services are within James's and Crumlin. So the standard pathway currently, if you require germline testing and it is in the public system, is to be referred there before you get a test. But the sort of mainstream pathways are being put in place. So some of those would be through having a medical oncologist with an interest in genetics, and I suppose that's being built currently. So depending where someone is in the country, they may start to see the benefit over the next year or so in terms of having more local testing. So a couple of hospitals have that, which would be mainstream testing for somebody who has a cancer diagnosis already now, as opposed to somebody with an increased risk of cancer. It needs to go through a different assessment process. I think sometimes it's the waiting times for specialist services. I mean, that's definitely something we're conscious of and trying to build the mainstream services, and that's maybe part of why people have felt the need to maybe go down the private route to get tested. So,
and Fiona, would that be with the cascade testing? So, you mentioned if you were worried with a family history or things, but is that private testing or is that through the public system?
So, I mean, cascade testing again is through the public, yeah. So if somebody's identified with a gene variant, then their relatives, can all automatically be referred into the service. It's the time and getting that. I mean, the ideal is that the more mainstream testing we can do, where people actually with the cancer diagnosis can get the testing done by a team that's looking after them already and that's comfortable with that. And then the specialist service, such as the genetic counselors, it's kind of, I don't say it's a bigger deal, but if you think if someone doesn't already have a cancer diagnosis and they're having a test to see if they have something which could put them at higher risk, then that tends to sit more within that specialist service. But yeah, that's still within the public service. Yeah.
Thank you. Paul has a question: is there an estimate on the prevalence of the BRCA variant in the Irish population and also the prevalence of Lynch syndrome?
Oh, I'd love to give you a really firm answer, but because we're talking about trying to develop a cancer predisposition registry and how best to do that. So it would be lovely if you ask me in 12 months, maybe. I can't say from BRCA, the needs assessment we did estimate around 3,000 women in Ireland. Now that could definitely be an underestimate. But by the logic, we probably have the same number of men. It's just they're not, going to present, because you can get male breast cancer and prostate cancer related to BRCA, but it's sometimes, harder to find them and harder to find them under surveillance when we don't have a clear database. So if you think in terms of breast cancer, in terms of the cancers that they're causing, like 5 to 10% of breast cancers are probably related to genetic risk, and then about 20% of those are linked to BRCA. So that's another way of looking at it. But obviously we have, as I said, those 3,000 people that I'm talking about in the system, they don't all have a cancer yet, and hopefully won't. Lynch, again, I'm sorry, I don't have a number off the top of my head, but I can tell you that from the international estimates, we know that it's very underdiagnosed, not just in Ireland, but in a lot of countries. It's felt, it's under-recognised, and there are systems kind of being put in place to do more tumour testing of those 3 common cancers, that I talked about that would guide you towards people who should have lynch testing. So that is a path that's going to come in to help us understand that. So.
Very good. And the last one is Sinead has put, can the somatic variant gene be transferred to offspring? Claire, I think you covered some of that.
Yeah, no, the somatic variant, we can't pass it on. It's something that we acquire over time as our that evolves. So no, we can't pass those on. Well, yeah.
Yeah, thanks a million. It was phenomenally interesting. I think if you haven't already looked, the IIOP have a cancer care hub, and there's a lot of the links that you talked about there. And as you said, with the webinar, there's going to be a resources sheet with a lot of the resources that you mentioned tonight, which I think are phenomenally useful. But there's really good patient information leaflets there, and some of the regimes and the supportive regimes and preventative webinars. So it's well worth a look. And so, yeah, everyone's saying great session. Thanks so much. So with that, just to remind everyone to fill out the post-webinar what do we call it, survey that's there in the chat box, and to tell us what you thought of tonight and also what ones you would like to see coming in the future. And to remember to do a CPD cycle tonight. You might as well open it while you're online and just get it done, and because I think we all learned an awful lot tonight, so thank you very much. And that our next webinar is in 2 weeks' time, on Wednesday, the 12th of March at 8 p.m, and it's the new Patient Safety Act with the National Open Disclosure Office. So thanks very much, everyone, and have a good night.